This recording will go over stomatitis. Stomatitis is a broad term that refers to inflammation within the oral cavity. It may present in many different ways. Painful single or multiple ulcerations, called aphthous ulcers or cankersers, that appear as inflammation and erosion of the protective lining of the mouth are one of the most common forms of stomatitis. The sores cause alterations in comfort, and open areas place the patients at increased risk for bleeding and infection. Mild erythema or redness may respond to topical treatments. Extensive stomatitis may require treatment with opioid analgesics and/or antifungal medications, depending on the source of inflammation. Stomatitis is classified according to the cause of the inflammation. Primary stomatitis, the most common type, includes aphthous non-infectious stomatitis, herpes simplex stomatitis, and traumatic ulcers. Secondary stomatitis generally results from infection by opportunistic viruses, fungi, or bacteria in patients who are immunocompromised. They can also result from drugs such as chemotherapy. A common type of secondary stomatitis is caused by Candida albicans. Candida is sometimes present in small amounts in the mouth, especially in older adults. Long-term antibiotic therapy destroys other normal flora and allows the Candida to overgrow. The result can be candidiasis, a fungal infection that is very painful. Candidiasis is also common in those undergoing immunosuppressive therapy, such as chemotherapy, radiation, and steroids. Stomatitis can result from infection, allergy, vitamin deficiency, systemic disease, and irritants such as tobacco and alcohol. Infectious agents such as bacteria and viruses may have a role in the development of recurrent stomatitis. Certain foods, including coffee, potato, cheese, nuts, citrus fruits, and gluten, may trigger allergic responses that cause aphthous ulcers. In some cases, strict diets have resulted in the improvement of ulcers. Recurrent stomatitis is at least partially related to genetic predisposition. Proper oral hygiene can discourage the frequency and severity of stomatitis. However, it may not completely prevent all occurrences, since stomatitis has been associated with numerous conditions such as bacteria and fungal infections, higher stress levels, certain medications, nutrition deficiency, and oral irritants. Older adults are especially at high risk for candidiasis because aging causes a decrease in immune function. The risk increases for patients who have diabetes, are malnourished, or are under emotional distress. Many older adults take multiple medications that can contribute to oral dryness and decreased salivation as well. Those who wear dentures may use soft denture liners that provide comfort, but also may be colonized by Candida albicans, contributing to denture stomatitis. In addition, older adults who have poor oral hygiene are at a high risk for mouth infections and aspiration pneumonia. Improved oral care could greatly improve patient outcomes, especially for older, intubated adults in critical care settings. When performing an oral assessment, ask about a history of recent infections, nutrition changes, oral hygiene habits, oral trauma, and stress. Also collect a drug history, including over-the-counter drugs and nutrition and herbal supplements. Document the course of current outbreak and determine if the stomatitis has occurred frequently. Ask the patient if the lesions interfere with swallowing, eating, or communicating. The symptoms of stomatitis range in severity from a dry, painful mouth to open ulcerations, placing the patient at risk for infection. These ulcerations can alter nutritional status because of difficulty with eating and swallowing. When they are severe, stomatitis and edema have the potential to obstruct the airway. In oral candidiasis, white plaque-like lesions appear on the tongue, palate, pharynx, and buccal mucosa. An important way of knowing that it's candidiasis is when these patches are wiped away, the underlying surface is red and sore. Assess the mouth for lesions, coating, and cracking. Document characteristics of the lesions, including their location, size, shape, odor, color, and drainage. If lesions are seen along the pharynx and the patient reports dysphagia or difficulty on swallowing or throat pain, the lesions might extend down the esophagus. When assessing the patient with stomatitis, be alert for signs and symptoms of a dysphagia, such as coughing or choking when swallowing, a cessation of food sticking in the pharynx, or difficulty initiating the swallowing process. If dysphagia or problem swallowing is suspected, A referral to the speech-language pathologist is needed. Document all findings and report these to the primary healthcare provider because dysphagia can cause numerous problems, including airway obstruction, aspiration pneumonia, and malnutrition. The patient with stomatitis is expected to regain a healthy oral cavity. Indicators include absence of oral and esophageal lesions and pink, moist, intact mucosa free from signs of inflammation or infection. Interventions to preserve tissue integrity include good oral hygiene and drug therapy. Interventions for stomatitis are targeted toward health promotion and reduced risk for infection through careful oral hygiene and food selection. When providing mouth care for the patient, you may delegate oral care to a UAP. Because you are accountable for the delegated task, remind the UAP to use a soft bristle toothbrush or disposable foam swabs to stimulate the gums and clean the oral cavity. Use toothpaste that is free of sodium lauryl sulfate, if possible, because this ingredient has been associated with stomatitis. Follow up by inspecting the patient's oral cavity after the UAP completes the task. Teach the patient to rinse the mouth every 2 to 3 hours with a sodium bicarbonate solution or warm saline solution. He or she should avoid most commercial mouthwashes because they have high alcohol content and can cause burning sensation in irritated or ulcerated areas. Teach the patient to check the labels for alcohol content. Frequent, gentle mouth care promotes debridement of ulcerated lesions and can prevent superinfections. Please review Chart 53-2, Care of the Patient with Problems of the Oral Cavity. Drug therapy for stomatitis includes antimicrobials, immune modulators, and symptomatic topical agents. Antimicrobials, including antibiotics, antivirals, and antifungals, may be necessary for the control of infection. Tetracycline syrup may be prescribed, especially for recurrent aphthous ulcers. The patient rinses for 2 minutes and then swallows the syrup, thus obtaining both a topical and systemic therapeutic effect. A regimen of IV acyclovir is prescribed for immunocompromised patients who contract herpes simplex stomatitis. For fungal infections such as yeast, nystatin oral suspension swish and swallow is most commonly prescribed. Immune modulating agents may be prescribed as second-line therapy. Over-the-counter benzocaine anesthetics and camphorphenol can also control alterations in comfort. Viscous lidocaine may also be prescribed as a gargle or mouthwash. Magic mouthwash is a mixture primarily made of lidocaine, Benadryl, Maalox, Carafate, and glucocorticoids, and is also commonly prescribed for those with oral pain due to cancer treatments. Dietary changes may help decrease discomfort. Cool or cold liquids can be very soothing, whereas hard, spicy, salty, and acidic foods or fluids can further irritate the ulcers. Include foods high in protein and vitamin C to promote healing, such as scrambled eggs, bananas, custards, pudding, and ice cream, unless the patient has lactose intolerance. Teach patients to use viscous lidocaine with extreme caution because its anesthetizing effect may cause burns from hot liquids in the mouth and/or increase the risk of choking.